morning, everybody. So I will talk about one of the most devastating complication of globe perforation. Okay. Basically, nowadays we all are doing cataract surgery under topical anesthesia, but days were there where people are used to do, even today also people are used to do the cataract surgery under peribulbar anesthesia or retrobulbar anesthesia. And you know, sometimes you have given the peribulbar block, or sometimes your colleague, anesthetist colleague, he has given the block. So this kind of problem may be arised in any situation. So I will discuss few of my case series where the patients were referred to me for the management. And see the varieties of cases where okay. Is it okay? Audio is there? Thank you. So I'm starting my case series.
Good safe anesthesia is essential for any intraocular surgery. Conventional methods for peribulbar block, injecting the anesthetic solution outside the muscle cone, and retrobulbar blocks inside the muscle cone. Inferior injection is given at the junction of outer 1/3 and inner 2/3 of the lower orbital rim, directing towards the apex of the orbital muscle cone. Superior injection is given usually nasally just above the medial canthus along the supraorbital bony notch, but in high myope or faulty needle direction can lead to globe perforation by the needle. Ultrasonography revealed vitreous hemorrhage with vitreous tract formation with retinal incarceration. Simply injecting the anesthetic solution outside the muscle cone, directing towards the apex of the orbital muscle cone. Superior injection is given usually nasally just above the medial canthus along the supraorbital bony notch, but in high myope or faulty needle direction can lead to globe perforation by the needle. Ultrasonography revealed vitreous hemorrhage with vitreous tract formation with retinal incarceration. Simply laser photocoagulation around the slit-like superior break sometimes save the eye in single break scenario. Secondary break can form due to retinal injury. Globe perforation can present with vitreous hemorrhage with a superior break with vitreous incarceration, or it can present with vitreous hemorrhage with inferior secondary breaks and superior primary break with partial retinal detachment. Settling retinal detachment and balancing the breaks with laser photocoagulation with gas tamponade is enough. Globe perforation can lead to retinal detachment, like in this case associated with dense vitreous hemorrhage with retinal detachment severely complicated the scenario. Multiple breaks near the disc detected, PFCL injected, a superior entry site detected, secondary breaks as well as the primary entry breaks were barraged and ensured with silicone oil tamponade. Even a well-done scleral buckle case was failed with subretinal band formation due to perforation during periocular anesthesia. Subretinal band removed, incarcerated detached retina was released from the site of perforation. and retina was made settled. Laser barrage around the retinotomy and perforation site done. Needle can directly hit macula, carries very poor prognosis. In a surgery for pterygium excision, macular secondary breaks happen with vitreous hemorrhage and retinal detachment. Primary supratemporal slit-like break indicated the wrong site of superior block. Triamcinolone assisted PVD induction done. PFCL injected. Peripheral vitrectomy completed with vitreous base excision. Macular rim removed. Fluid exchange done. Laser barrage completed around the bricks. Silicone oil was used as a tamponade. This was an abundant case of phacoemulsification, presumed to be a case of globe perforation. Capsulolysis completed under no glow situation. Phacoemulsification completed and IOL was implanted in the bag. After removing vitreous hemorrhage, hemorrhagic retinal detachment detected and posterior pole slit-like secondary break with macular extension found. Subretinal blood removed. Incarcerated retinal tags released. Primary entry break detected inferiorly. Retina settled by direct fluid exchange. Posterior pole break as well as peripheral break lasered. 360-degree barrage laser done and the case was ended up with silicone oil injection. This was another case of abundant phacoemulsification with red glow. Phacoemulsification completed, IOL implanted, hemorrhagic retinal detachment detected after clearing vitreous hemorrhage. Superior multiple primary entry breaks detected, subretinal blood removed, 3 more secondary breaks detected along the superior major vascular arcade, fluid exchange done to settle the retina, laser barrage done around the breaks with silicone oil injection. So, globe perforations are salvageable if intervened early. Topical anesthesia should be preferable mode of anesthesia. Whenever possible, one should follow the right technique and the right site for periocular anesthesia.
Thank you. Also, any question?
Yes. So, do we have time for questions now, or we go on for the next session? So, we probably have time just for the group photo. Yeah.
After you know that there is a globe perforation,
Yes.
you know that there is a vitreous hemorrhage, how many days do you wait, or you take that patient immediately?
Immediately.
Immediately.
We should not wait because it is not like if you are not
If there is
sure,
no RD in those cases, some
even only one like I have faced only one case, that is the directly hit the supracortical space. That means I have my assumption was something else, maybe subretinal hemorrhage, but on table when I gone inside, it was supracortical hemorrhage, kissing choroidals. That was the toughest case in my life, that to remove that supracortical hemorrhage just without giving sufficient time for the clot lysis. That was the most devastating situation. Otherwise, you have to do it immediately, as early as possible.
All right. With that, we